Knee rotary instability. There are many types of rotary instability, such as anterior or anteromedial instability, but these varieties are more clinically obvious, straightforward, and less complex. So current research in this presentation will focus on the role of the posterolateral corner. Recognize that there are several structures in the posterior and lateral aspects of the knee. However, these three structures are key to the posterolateral corner. Here are some important facts about the biomechanics of the posterolateral corner. The LCL is the primary restraint to varus translation of the tibia. The popliteofibular ligament and the popliteal muscle tendon work together as secondary restraints to varus translation. If the LCL is absent, ACL and PCL are secondary varus restraints. PLC structures are primary restraints of tibial external rotation, maximal at 30 degrees of flexion, also function as secondary restraints to posterior translation. Posterolateral rotary instability mechanism of injury. Combined varus and hyperextension force, forced external rotation. These are most often combined with collateral ligament damage, PCL, ACL damage, or both. And you see the statistics there for MVA, sports, and falls. Incidence and etiology. It's important to note clinically that isolated PLC injuries account for only less than 2%. I believe the number is 1.6% of acute knee injuries. ACL reconstruction causes a persistent pivot shift in greater than 15% of cases. The main cause of graft failure is unrecognized and untreated posterolateral rotary instability, which makes this topic so important for us. Here you see in 432 ACL reconstructions from 02 to 07, 54 knees were found to have concomitant posterolateral rotary instability. And then you see PLC injury concomitant in up to 60% of PLC injury. So the takeaway here is that most of the time you're going to see other ligaments involved with these injuries. A clinical presentation for the acute patient. You'll see posterolateral pain, edema, buckling during the stance phase. For the chronic patient, medial lateral joint line pain with posterolateral pain, as well as hyperextension going up and down stairs. And as stated previously, the incidence of ACL and PCL concomitant injuries. So you see the post-op there. Need to make sure we screen these patients for posterolateral corner instability, just in case. Physical examination, you of course have observation and your palpation, and certainly a neuro screen. For acute, you have common fibular nerve involvement in up to 30% of cases, and that is definitely noteworthy there. And then a myotome foot drop and functional heel walk is also worthy to note. Continuing with physical examination, neuro screen, evaluate popliteal, posterior tibial, dorsal, pedal pulses, as well as gait observation. For special tests, there's not really one test that's perfect, and there's not a cluster either, but here are a few tests that are worth your time. Here is some information on the dial test to detect posterolateral corner and PCL injuries. And this test is for ACL and posterolateral corner injuries, and it's the external rotation recurvatum test. Patient reports are important for outcomes as well as measurement of laxity and tibial translation. Here's a brief overview of the grades for PLC injury. Just be aware that there are other scales out there, so it's important to note what scale the physician is using. For imaging, X-rays can be helpful. MRI is more of a gold standard, can see more comprehensive, get a more comprehensive look at the knee. Treatment, as with most things, is based on severity and timing. As noted before, there are different grading scales, and here are 3 other grading scales to be aware of. So here's a nice algorithm. You can see where conservative treatment is indicated with the grade 1 and the mild to moderate grade 2, and you can also see that it is important for the more severe grade 2 and all of grade 3 to have surgery within 3 weeks for better outcomes. Conservative management is not well documented, most likely due to the fact that these injuries are most often combined with other ligamentous injuries, or the patients have a grade 1 or mild to moderate grade 2 and do not present for treatment. If you do have one of these patients, grade 1 or mild to moderate grade 2, here are the phases for conservative management. Once the prerequisites are met, they enter into phase 2, and then again you'll see the prerequisite there at the bottom for entering into phase 3. Phase 3, neuromuscular control and strengthening with functional movements. And then you see once the patient has achieved a limb symmetry index greater than 85% on functional testing, they can progress to phase 4. And phase 4 is the sport-specific rehab. And as mentioned before, posterolateral corner injuries are often treated surgically. And so here are some references for different types of surgeries that may be involved with that posterolateral corner. Post-surgical rehabilitation, it is important for the therapist to consult the physician and to review operative notes due to the variation and complexity among surgical procedures. Therapists should have an understanding and appreciation of postoperative precautions and restrictions to assist with optimal outcomes. That is the bottom line, really, of post-surgical rehabilitation. Early phase of graft healing is from about 0 to 4 weeks post-op and is marked by increasing necrosis with decreased mechanical strength until about the 6th week post-operatively, and therefore weight bearing is restricted during this time. At 6 weeks post-op, patients may progress to phase 2 of rehab. If they have no signs of effusion, can demonstrate a supine straight leg raise without a knee extension lag, exhibit 0 degrees of knee extension, and have greater than 120 degrees of knee flexion. At 3 months post-op, patients will typically follow up with a physician for further clinical examination and clearance for further activities. These activities include beginning to use a squat rack with 50% body weight, while continuing to maintain a depth above 70 degrees of knee flexion. And then patients can progress to full body weight over the course of the next few weeks. At the 4-month period, patients can begin a daily walking program at a brisk pace. And then the patient will follow up with the physician at 5 to 6 months postoperatively for further evaluation and various stress radiographs. Functional testing is performed between 5 to 7 months post-op. Patients should be aware that it may take up to 2 years to recover from an injury and surgical reconstruction of the PLC, especially with concurrent cruciate ligament reconstruction, or for patients who required a staged reconstruction after an osteotomy. Here are a few bottom line statements. Rotary instability often occurs with concomitant ligamentous injuries. This makes it difficult to detect and accurately diagnose in the physical exam. Undiagnosed and therefore untreated PLRI leads to poor outcomes in ACL and or PCL reconstructions and increased risk of degenerative changes in the knee. We should, as PTs, recognize the type of surgical intervention performed in order to appropriately prescribe an exercise program.